hand. But if you have an immobilizer, as the term indicates, it immobilizes the shoulder completely so that the pain is reduced maximum. So if the injury is maximum, or if this is a massive injury with the fracture or without fracture, better to use a elastic shoulder immobilizer. Okay, even if the pain relief in case of soft tissue injury after 3 weeks of immobilization, you start with the exercise. If in case of a fracture after 1 month, start the exercise, especially pendulum exercise. Range of motion exercise start, especially the pendulum type exercise is a very important rehab protocol. Start with the pendulum exercise. Okay. In some cases, you have to go for surgery even after immobilization of 3 weeks, and after 3 weeks, start with the rehab protocol, and even after 2 to 3 months of your treatment, if the pain is not getting relieved, you go for an MRI, and there are certain cases you have to directly go for a surgery. So I will explain that. Okay. Pendulum exercise. So this is the orthotics used in shoulder. You can use a simple shoulder bandage, and you can use an elastic shoulder. It is very easy in clinical practice. It is a shoulder mobilizer, but very difficult to use for the patient. It's more comfortable. Elastic 400 to 450 rupees. Okay. Elastic shoulder mobilizer. It will reduce the pain because of the strict immobilization. So it is the elastic shoulder immobilizer. Medium, large, small, XL sizes are available. Is available in the orthotic or in the surgicals. Okay. Elastic shoulder immobilizer. And if a patient came to OPD with a recurrent shoulder location, it is only for the immobilization purpose. Okay. It is not a functional support. It is just for immobilization. Never use more than 1 month. Never use more than 3 weeks in soft tissue. Never use more than 1 month in injuries. But in case of a recurrent shoulder dislocation, to prevent further recurrent dislocation, you can use shoulder support. But it can use always. You can use 24 hours while swimming, you can use, while sleeping, you can use, while driving or during daily activities to prevent further dislocation. It is a functional support. You can use always. 24 hours you can use. But it cannot be used after 2 to 3 weeks. It can use for 1 or 2 or 3 years. Okay, along with shoulder strengthening exercise. So it's a functional support known as a shoulder support. The name is shoulder support for the recurrent dislocation of the shoulder. Okay, it is not a structure, it is a functional support. You can use continuously for a long time with the specific exercise is better. It is the pendulum exercise. Okay. Another one is the biceps tendonitis and isolated heavy shoulder strain. The biceps tendonitis is very important, and the pain radiated from in deltopectoral area along the biceps tendon, and it radiate along the anterior arm. Okay, and the biceps tendonitis we can use the Spiritus restricted flexion with the slightly flexed forearm supinated. Okay, like this, slightly flexed forearm supinated. This is supination. Okay, and you can restrict your flexion. Restrict the flexion, and you will develop a pain on the anterior aspect of your arm. This is the Spiritus and Yogasam test. So this is it is very important because biceps tendonitis is usually associated with the rotator cuff, because it start from the biceps tendon, the long head of biceps start from the supraglenoid tubercle. Okay, supraglenoid tubercle. So in case of slap lesion, biceps tendonitis is usually affected, and in case of a massive rotator cuff tear, biceps tendonitis is usually affected. In another case, biceps tendonitis usually associated with the rotator cuff tear. It is the important thing. Biceps tendonitis usually associated with the rotator cuff tear. If a patient is having no rotator cuff tear, the chances of biceps tendonitis is heavy weightlifting. Okay, as in AC joint, heavy weightlifting osteolysis. Same way, the heavy weightlifting is another cause, individual cause of biceps tendonitis. Otherwise, biceps tendonitis is always associated with the rotator cuff tear. And there are two tears. This is the two cases came to my OPD, and there are two. You can see there are two origin. One is the supraglenoid tubercle, that is the long head, and another one is the coracoid process, short head. So if there is a biceps tendon rupture Usually, long head of biceps is ruptured. We can see a Popeye appearance, like a mass dragging down. This is a Popeye appearance. That means it's like a rubber. If you are removing, it will come downward. Like this, if the long head of biceps, there is a rupture of the long head of biceps. In such cases, there is a mass like Popeye appearance. So if a patient appear like this, the mass in the lower end of the upper arm, and there is an area, there is a shallow groove over the above area. That means the greater long head of biceps is ruptured. In such cases, no need of immobilization. If the patient present with a pain, 2 to 3 week immobilization is enough. There will be no surgery. It is conservative. So long head of biceps, Popeye appearance we can see in the lower area, and there will be a shallow area over the upper area. Okay, if you are curling your biceps curl, you can see a Popeye appearance in the lower end. There will be a shallow area in the upper. It is the long head of biceps rupture, and the treatment is 100% conservative. And in opposite, there will be rupture of the insertion. You can see there will be insertion in the bicipital area, bicipital groove. Okay, if the insertion is ruptured, the tendon go upward like this. There will be area here. This case is 100% surgical. It's very, very important. It's acute surgical if the biceps tendon insertion is ruptured. The origin is ruptured. There will be two origin. Long head is ruptured. There will be short head, no problem. If the patient is present with the pain, immobilize for 2 to 3 weeks. Otherwise, no immobilization. But there will be a weakness, lifelong weakness, if patient is having a biceps rupture origin, especially long head origin. But in case of an insertion rupture, definitely you go for a surgery. And in the apply scratch test, so this is the scratching, and this is the scratching, and this is scratching. If a patient having pain, to diagnose whether it is a shoulder injury or a cervical injury, so you do this apply scratch test, scratching like this and like this and like this. If a patient is having pain on the 3 movements, it means it is a shoulder pathology. If a patient is having no pain in this movement, it means it is another visceral pathology or a cervical, etc. Okay, in next one is the periarthritis of the shoulder. This is the most important concern without non-traumatic concern of your shoulder. It's a very important pain, constant, worse at night and with cold weather. It is very, very important, dear doctors. Note the points that patients having normal activities in the daytime. Normal activities in the daytime. It is very, very important. Normal activity not affected in the daytime. But the pain will be increased at the night. It's the most important pain. You ask the patient, if patient is having pain aggravate or whether it aggravate on the night. This is the first point. Pain aggravate over the night. This is the first point of the periarthritis. And there will be normal activity, normal daily routine activities will not be affected in the periarthritis. And patient may present, if the patient is a lady patient, it may affect while combing her hair. Okay, and after bathing, and while doing, by internally rotating, like by wearing maxi or using bra, etc., the pain is maximum. That if a patient get a internal rotation, like scratching the back, okay, while combing her hair, okay, while washing her hair, combing her hair, okay, and while using maxi or blouse, etc., while using bra, etc., she may develop a pain. In all other activities, that means activities with the internal rotation, patient may develop a pain. In all other daily activities, there will be no pain over the shoulder. And it will be aggravated at the night while sleeping. The patient usually present, doctor, I am not having any pain in the daily activities, but while going to bed, when I reach the bed, pain starts. This is the usual presentation of the patient. Normal daily routine activity and pain after sleeping or while entering your bedroom. It is the typical presentation of a periarthritis of the shoulder. That means if a patient presented with normal daily activity in the daytime, pain aggravated over the night, Any activity aggravate with the internal rotation of the shoulder, like using bra or maxi or combing hair or washing your hair, the patient will develop a pain. It is the typical presentation of the periarthritis of the shoulder. Initially, patient presented with the pain on the flexion, like this. Pain while lifting your hand. Pain and along the shoulder while lifting your hand. Patient initially developed pain on the flexion of the shoulder. And the typical presentation is the patient can't sleep with this position. Patient can't sleep with externally rotated hand. It is very, very important. Patient adopt a position of internal rotation. That means patient place the hand over abdomen over thigh. He can't sleep with this externally rotated position. This is a typical presentation of periarthritis of the shoulder. Okay, and in later stage, initially flexion is restricted, and in later stage, patient present restricted internal rotation. Initially, flexion is restricted, and later internally rotation is restricted. And it may be a trauma, it may be an autoimmune, it may be a deficient blood supply, and mostly diabetes. If the patient is having diabetes and it is severely restricted, you can term the periarthritis as the frozen shoulder. So in such cases, initially there will be inflammation over the synovial joint. So there will be inflammation in the initial stage, and later there will be contracture or there will be restricted adhesion of the shoulder. That is why it is called adhesive capsulitis. Joint capsule inflammation or synovial inflammation, and because of the inflammation there will be pain and restricted movements, and due to the chronicity there will be adhesion over the capsule. So it is the periarthritis or adhesive capsulitis. That's why if you are familiar with mobilization techniques of the shoulder, especially the static stabilizers, you can relieve periarthritis easily than any medicine. If you are not treating periarthritis for 1 to 1.5 years, there will be automatically relieve the pain. Okay, 1 to 1.5 years, the pain is completely relieved, and it may again develop. That is the importance of periarthritis of the shoulder. And the management of periarthritis is, first is never immobilize a patient. Never immobilize a patient. In our practice, it is regularly we are seeing that any patient shoulder pain, yes, bandage. So bandage is 100% contraindicated in periarthritis of shoulder. Bandaging is contraindicated. Immobilization is contraindicated. You can have laburnum or bandage like ubanaham, no problem. But immobilization is contraindicated in the periarthritis of shoulder, first thing. And second one is maximum range of motion exercise is the ideal choice for managing the periarthritis of the shoulder. Is very important. Synovitis followed by a contracture. This is the pathology. Okay, there are pathology you can use, maybe intrinsic or extrinsic factors. These are the many pathologies behind. Okay, painful active and passive glenohumeral joint, loss of external rotation with the arm at the side of the patient. This is very important. Patient tell the same. Okay, കൈ ഇങ്ങനെ ചെരിച്ചു വെച്ചിട്ട് കിടക്കാൻ പറ്റില്ല, രാത്രി ഭയങ്കര വേദനയെന്നാ പറയാ. Okay, comfort in adducted at the side and internally rotated. This is the very important diagnosis. Loss of passive external rotation. Okay, and OP lever management, inflammation, Amapadina Shobhara treatment, Amrodotaram Purnavadi and Rasnerandadi. If it is severe pain, Purnavadi is the ideal choice. And after that, Amrodotaram plus Purnavadi, and later Amrodotaram and Rasnerandadi. After 3 weeks, after relieving the pain, along with exercise, the Anadanadi Kashayam, Ashtavaragam Kashayam. Okay, Anadanadi and Ashtavaragam is the ideal choice. And if it is an adhesive capsulitis, use Sahajaradi Avarti Thailam, Sahajaradi 21 Avarti Thailam. Okay, this is a stricture, this is a contracture. To relieve the contracture, there is Snehana of the joint, and you can use Chandraprabha. I am using Chandraprabha 2 tablet before sleep. Okay, not in the morning, before sleep, because it is Urdhanga. And you can use Yogaraja and Kanchanara Gugulu. Kanchanara Gugulu is ideal in the chronic cases only. Okay, and Chandraprabha, in all cases you can use Chandraprabha. If the pain reduces after the subsiding the severe pain, you can start the rehabilitation. And it is very important that the range of motion exercise and start with the pendulum exercise, because pendulum is pain-free exercise. Okay, and the last stage you can have Sneha Prayoga. And in our classics, that Ababahugam, the typical Ababahugam, we can correlate with the periarthritis of the shoulder. Okay, is the management, and considering the Pitta, Prasaranadi, then Adananadi, and Ashtavarna you can use. And with the severe pain, Danyamla Dara, Danyamla Kiri. Okay, Shmasweda, Jambira Pindasweda, and if the pain predominates, you can have Kshiradhara, especially Dashamula Kshiradhara. And moist heat in the beginning of every treatment is very, very important. Before doing any exercise, moist heat in the beginning. That means our Sweda Prayoga. It is the modern treatment protocol. Moist heat in the beginning after every treatment, and after range of motion exercise, patient may develop some inflammation and pain. So at the end of the exercise, you can have ice pack for 10 minutes. It is very, very important. Okay. This is a pendulum exercise for the shoulder and shoulder. Finger walking. Okay, passive shoulder abduction. Okay. It's very, 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 very important. You have to adopt exercises in your clinic. In my practice, I am using maximum exercise and with less medicine. So in case of frozen shoulder periarthritis, the most important tool is the exercise, not medicine. Okay. So you have to adopt this type of exercise. Okay. And the strengthening exercise, usually in after injury, okay, the another one is the shoulder impingement. So the periarthritis of shoulder is over. Another one is the shoulder impingement. Okay, shoulder and the tendon of the rotator cuff muscle get irritated and inflamed while passing through the subacromial space beneath the acromion. This is the very, very important. What is the shoulder impingement? The rotator cuff tendon muscle get irritated and inflamed while passing through the subacromial space beneath the acromion. It is very important. We can see it is a normal. It is the supraspinatus tendon. Okay, supraspinatus tendon. It is the AC joint. It is the AC joint subacromial arch, thoracoacromial arch. So it is the space. This is the space. You can see this is the base. This is called the subacromial bursa. There are area. This is the thoracoacromial arch, and it is the shoulder humeral head. This is the gap between thoracoacromial arch and humeral head is the subacromial space. It is usually 7 m to 14 mm. So in that area, there will be a bursa, it's a fluid-filled bag for, this is the bursa, subacromial bursa. Okay, this is the primary action of the bursa to avoid irritation, direct irritation, to protect the rotator cuff muscle. And in case of, and already told the superior migration, if the humeral head is migrated upward, that means the space, that is the 14 mm or 7 to 14 mm spaces get reduced. Okay, if it is the normal position. If it is superiorly migrated, means the humeral head is in this area, so the area subacromial space is reduced. So there will be inflammation and irritation while passing through the subacromial space. Okay, so the normal space is reduced by the superior migration of the shoulder. So in such cases, if you are abducting your shoulder, like this, usually there will be 14 mm space. If it is superiorly migrated, the space is reduced. So there will be inflammation and irritation of the subacromial bursa. So it is called subacromial bursitis. And there will be a chance of the rotator cuff tear. That is a supraspinatus tear. So any condition that result in the inflammation and irritation of a subacromial area or rotator cuff muscle is called the shoulder impingement. So because of the superior migration of the humeral head, the space is reduced. There will be 7 to 14 mm space. Because of the superior migration of the humerus, like this, there will be normal space. If the superiorly migrated, the space is reduced. So the rotator cuff muscle has to pass through the area. So during the abduction, there will be irritation of the supraspinatus bursa. It is called the supraspinatus bursitis. Or there will be a tear of the supraspinatus tendon. So it is called the shoulder impingement. Okay, and the term is also called the painful arc syndrome. The patient arm is passively abducted from the resting position. The pain in the acromioclavicular joint occurs between 140 to 180. In the initial slide, AC joint pathology, if the pain starts above the 120 degree and there will be maximum in between 140 to 180, it is called shoulder. It is maybe AC joint pathology. So in AC joint pathology, pain will be maximum in this area. Okay. If you are starting abduction, okay, increasing abduction leads to increasing the compression. So in up to 70 degree, up to 60 to 70 degree, the abduction is the up to 60 to 70 degree, the shoulder from the starting position is the normal position. From normal to 60 to 70 degree, the abduction is done by supraspinatus and the deltoid muscle. Supraspinatus and deltoid up to 70 degree, the abduction is basically from the deltoid muscle and supraspinatus muscle. And from 70 to 120, the abduction is controlled by the supraspinatus muscle. So this is called the painful arc. Okay, so normal abduction. Abduction means subabdominal space is reduced, and I am internally rotating my shoulder means it is moving upward. Okay, so this is a normal subacromial space. Okay, this is the space. Normal 14 mm space. If I am abducting my shoulder, the space is reduced. After abduction with internal rotation means humerus is superiorly migrating like this. This is the internal rotation. While doing internal rotation, the subacromial space is normally reducing. So by abducting the shoulder, abducting the shoulder, subacromial space is reduced, and with the repeated internal rotation, this subacromial space is again reducing. So by activity with abduction and internal rotation, there will be continuous irritation of the superior subacromial space and subacromial bursa. So if you are doing abduction and internal rotation regularly with this internal rotation, that cleaning, window cleaning or bathroom cleaning or tabla, etc., there will be reduced subacromial space and a continuous irritation of the subacromial bursa. So it may develop subacromial bursitis. Bursa will inflame. Okay. So after inflammation, if you are abducting your shoulder, it will be severe pain. Or it may develop a chronic rotator cuff tear. You can see in MRI rotator cuff tendinosis. Tendinosis means a degenerative tear because of the chronic activity of the shoulder. So the rotator cuff impingement, the final result of a rotator cuff impingement is the rotator cuff tear. Initially, it may present a rotator cuff tendonitis, chronic tendonitis or acute tendonitis. It may become chronic, and finally there will be a rotator cuff tear. Okay. Or there will be a chronic subacromial bursitis. Okay, and that case I already mentioned. After doing 1 week, one day, full day, night, tabla, it developed severe shoulder pain, maybe due to subacromial bursitis. So, if the patient after doing window cleaning position or bathroom cleaning or any other activity with abduction and internal rotation, if patient came to OPD within 5 days, you have to immobilize the patient for 2 to 3 weeks to relieve the subacromial bursitis. In such cases, you have to relieve the patient. You have to give rest or mobilize the patient for 2 to 3 weeks. If the patient came to OPD within 5 to 7 days. If the patient came to OPD after 10 or 15 days of the activities with severe pain, never immobilize the patient, but ask the patient to avoid abduction and internal rotation. If it is acute, immobilize the patient. If it is subacute or a chronic case, ask the patient never go for an abduction or internal rotation. It is the very important for the management of impingement. Medicine is not using actually, because if you are using typical medicines, but patient is doing the abduction, internal rotation, again there will be shoulder subacromial bursitis and impingement. So in acute case, or within one week, immobilize the patient for 2 to 3 weeks. If it is subacute or chronic case, you give medicine, you give external application, you give dara, etc. Along with, you have to restrict the patient abduction and internal rotation minimum for a 3 to 6 months. It is very, very important for the management of subacute impingement. Okay. What happens if you get a superior migration? Okay. It is normal for if it's superior migration, there will be tear of the rotator cuff. But I already told. Is the supraspinatus, but tendonitis, we already told. Okay. In case of next one is the suprarotator cuff tear, supraspinatus tear or tendonitis. The labana, it is very important in acute pain and inflammation. They may be in acute first 5 to 7 days. Use Nagaradi and Jadamayadi, and later Nagaradi and Grudumadi, and after that use Nagaradi alone or Kartavatte. Usually use Chinjas. I am usually using Chinjasurasa because it is anti-inflammatory and also anti-allergic. Surasa is ideal, and in chronic cases, if patient is having a tender point, you use Lera. Okay. And Prasarnati. If the patient is acute supraspinatus tendonitis, Purnamadi Kashaya with Vetamaran Guliga, it is the ideal choice to reduce the pain. And in case of a chronic case, Nanadi and Prasarnadi. Prasarnadi is tendinosis. It is called a tendinosis. That is a degenerative tear. Prasarnadi Kashaya with that Maharaja Prasarni Thailam or Servilon capsule or Gandhailam capsule exercise you can use. Okay. And in case of acute supraspinatus shoulder injury, you can have cupping. Okay. And in case of a subacute chronic pain, Agnikarma is the choice, but you have to locate the pain in extension. Anterolateral aspect in extension, you will get a groove, that is the subacromial space. You have to do the Agnikarma in that peculiar area. Never use Agnikarma in whole area. You will not get any result. Okay. You can have, in case of a shoulder injury or a shoulder pain, Dhanyamla Dara. Dhanyamla Dara is Dhanyamla Kiri. Dhanyamla Dara and Dhanyamla Kiri, the apt choice if the patient is having a shoulder pain. Okay. If it is associated with injury, do Dhanyamla Dara initial stage. After that, Kshiradhara, Dashamula Kshiradhara, and after that Dashamulam and Dhanandara Kshiradhara is the ideal. Okay. And in case of a chronic case, chronic rotator cuff tear or tendonitis, for supporting that, for making the muscle tone, you have that Muttakiri, Eggkiri. Okay. You can use Muttakiri for strengthening of your shoulder with Brahmana type of thaila like Ashavanna, etc. Okay. And what is a rotator cuff tear? Rotator cuff tear, already told, typically in extension, in front and anterior and lateral aspect of the shoulder, and tenderness on the anterior edge of the acromion. This is the edge of the acromion. Pain down the arm toward the deltoid muscle insertion, already told. Long lever arm with the elbow extended, and there are tests. So these are the area of pain and tenderness and active abduction test. If the patient came OPD after a fall, you take an X-ray of shoulder. Okay, shoulder X-ray is normal, and ask the patient to abduct the shoulder. Okay, ask the patient to abduct the shoulder. Okay, if the abduction is normal, it means there will be no supraspinatus tear. If the patient, another one is the drop arm test. If the patient asks the patient to abduct the shoulder, patient can't do the abduction, so you give an passive abduction. You help the patient to abduct. Passive abduction, and if the doctor remove his hand, the hand fell down. This is called the drop arm test. Okay, ask the patient to abduct to 90 degree. The patient, if patient is not cannot do the abduction with the help of the doctor, that is the passive abduction up to 90 degree, and ask the patient, and if the patient remove his hand, if the doctor remove his support, the hand will drop down. It is called the drop arm test. If the drop arm test is positive, means there is a 100% supraspinatus tear. So for the confirmation of supraspinatus tear, drop arm test is using. If the drop arm test is positive, it means there will be 100% rotator cuff tear. And another one is the empty can test. Empty can test means ask the patient to abduct and a 30-degree flexion forward. Use a resistance against your abduction. Patient get pain over the shoulder, and if your hand like this, okay, it is the empty can. So do the abduction with the internal rotation. That is the thumb pointed downward like empty can, and again abduct. If the doctor resists against the abduction, if the pain is aggravated, it means the empty can test is positive. So if a patient came to OPD, he can abduct but having a pain. So the doctor resists the abduction. So if pain is more, and if the empty can test, if the pain is again aggravated, it means there is a rotator cuff tear, but there is no full thickness tear. In case of a full thickness rotator cuff tear, the drop-off test will be positive. If a patient is having negative drop-off test, but a positive painful arc sign, it means there will be a rotator cuff tear, but not a full thickness tear. Okay, this is a supraspinatus full thickness tear. So, is the suture anger. Usually, I am attending surgery. Is the suture anger. One or two suture anger we can use. It is the arthroscopic rotator cuff repair. Okay, arthroscopic rotator cuff tear. Acute tear or etiology, you can read. Okay, very, very important. And this is a drop arm test for supraspinatus and MT can test for supraspinatus. The drop arm test is positive only if patient is having full thickness, complete tear of the supraspinatus. Drop arm test is positive. You abduct the shoulder and just remove your hand, the hand will fall down. So it is a drop arm test. It is positive only in 100% tear, full thickness tear. But in empty can test, if a partial tear or a degenerative tear or a patient with supraspinatus impingement, a patient can develop pain resistance. If the doctor resists the abduction, he may develop a pain. And if the empty can position, if the pain aggravates, it means there will be a supraspinatus tear. It is called the empty can test. And another one is the external rotation lag side. And you see the external rotation of the shoulder is maintained, controlled by the infraspinatus and teres minor. Okay, it is the external rotation. So if the external rotation lag sign, if the external rotation is lagging, it means there is a tear of the infraspinatus muscle. Okay, and another one is the teres minor and infraspinatus, all boner sign. Okay, then belly press test and lift off test. If it is an offline class, I will show, but it is not possible actually to do the belly press and lift off test. There are so many tests for diagnosis of the rotator cuff muscle, but it is enough. Lift off test and belly press test for subscapularis, drop arm test and empty can test for supraspinatus, and external rotation resistance test for infraspinatus. These 5 tests are enough for diagnosing rotator cuff. Or you leave all other tests. Okay, it is enough. Okay, I will show the picture. Okay, rope arm test and empty can test and subscapularis lift off test and infraspinatus, that's the speed test for the biceps tendonitis. Okay, and if the patient came to OPD with the acute rotator cuff tear, that means patient came to OPD after a fall or a trauma, and you take an X-ray. X-ray is normal, but we can't abduct or move the shoulder. So you conclude that it is a soft tissue injury or a rotator cuff. So immobilize for 2 to 3 weeks with the shoulder, elastic shoulder immobilizer. Okay, after 2 to 3 weeks, start with range of motion exercise and isometric TheraBand later. Okay, in second phase of the acute injury, second phase means after to 10 to 15 days. Okay, after subsiding the pain, okay, after subsiding severe pain, you can use Mustadi Marma Kashaya, Gandhathaila, and Lakshagu. Is the ideal. Okay. After acute traumatic pain management, you can have local Dhanyamladara, Kola Kulattadi Churnam. Okay, Dhanyamla Kiri, Kola Kulattadi Churnam, 4 to 7 days. And Muttakiri with Ashavanna or Murivanna, local Shastika Lebana. And if it is a rotator cuff or a soft tissue injury, after Dhanyamla Kiri, you can use that Dashamula Chiradara and later Dashamulam and Dhanandara or Dhanandara Chiradara. And in case of a chronic injury, in case of a acute injury, up to Muttakiri or Ashavanna treatment is enough after immobilization. If it is a chronic tendinosis, have local Shastika Leban. Okay. Strengthening treatment in this is only this Prasarnadi, Maharasnadi, all is applicable only in the later stage. Only in the later stage after subsiding your pain. Okay, Panchatiktagam, Mahatiktagam, and Rasna Dashamula Grudam is the ideal choice. Okay. And another one is the shoulder instability. Instability of the shoulder, usually after recurrent dislocation of the shoulder. There are 3 reasons for the recurrent dislocation of the shoulder. One is the slap lesion. So considering a clock, it is your shoulder from the side. Okay, from the side. It is the shoulder clock. You can see. Can you see my shoulder, Doctor?
Yes, sir. Yes, sir.
Is the 12 o'clock position, the 3 o'clock position, 6 o'clock, and 9 o'clock. Okay, like a clock. So same. It is same like a clock. Okay, you can see it is the 12 o'clock, 3 o'clock, 6 o'clock, and 9 o'clock. Okay. So it is the labrum. This is the white is the glenoid labrum. Okay. And the reason for recurrent dislocation, if a patient came to OPD with recurrent dislocation of the shoulder or recurrent instability of the shoulder, there are 3 reasons, mainly 2 reasons. One is the Bangart lesion, another one is the Hill-Sachs lesion. Okay. And another one is the slap lesion. Superior labrum andro posterior. That is the slap. So we can see this is a labrum. So it is the superior area. So it is the inferior area. So superior labrum andro posterior. If you considering a clock, you can see this is the 2 o'clock position. This is the 10 o'clock position. So from 10 to 2, this is the superior labrum from 10 o'clock to 2 o'clock. Superior labrum anterior posterior. This is the slap lesion. So from the 10 o'clock to 2 o'clock. So superior labrum andro posterior. So there is a labral tear at the level of 10 o'clock to 2 o'clock. This is called the slap lesion. And there is the supraglenoid tubercle from which the biceps, long head of biceps tendon starts. So in case of slap lesion, there will be usually biceps tendon avulsion or there will be biceps tendonitis. Okay, so slap lesion means from 10 o'clock to 2 o'clock, superior labrum andro posterior. So in such cases, there will be shoulder instability, but there will not be any shoulder dislocation. There will be unstable joint, shoulder pain, so shoulder stabilization. There will be no dislocation. But in case of a Bangart lesion means andro-inferior labral tear. Andro-inferior labral tear. You can see this is 3 o'clock and you can see 6 o'clock. So 3 o'clock, 6 o'clock, this area, this is the andro-inferior area. So the andro-inferior area of the labrum is tear. So usually there will be andro-inferior dislocation of the shoulder. So if a patient is having a recurrent dislocation, there will be a repeated andro-inferior labral tear. So it may develop recurrent dislocation of the shoulder. And with the recurrent dislocation of the shoulder, the head of the humerus, posterolateral corner develop a shallow area that is called the Hill-Sachs lesion. So these are the 3 reasons for shoulder instability. Okay. So it is the labral tear, that is the superior area, 10 o'clock to 2 o'clock. So the labrum is tearing, superior labrum andro posterior. It is the slap lesion. It is very, very important. And there are 2 types of labral tear, slap lesion and Bangart lesion. Okay, slap tear start 10 o'clock where biceps angle typically extend from 10 o'clock to 2 o'clock position. Bangart lesion is 3 o'clock to 6 o'clock position. So I will show you the Bengard lesion. Antro-inferior glenoid labrum. In some MRI report, they never mention Bengard lesion, but they mention antro-inferior labral tear. So Bengard, it may be a Bengard lesion or a 3 o'clock to 6 o'clock lesion or a labral tear. Okay, you can see in X-ray. So in picture, you can see the labral tear. In acute stage, it is better to do surgery and do a Bengard lesion repair. It is the ideal choice. Never go for conservative management in Bengard lesion. If you are the MRI suggests if a Bengard lesion, you go for surgery directly. Never go for a lesion. Okay, never go for a conservative treatment. And in some cases of recurrent shoulder dislocation, we can see there will be a fracture or depression over the glenoid humeral head. It is called the heel sac lesion. I will show you the X-ray. A patient with a recurrent dislocation of this, there will be a shallow area developed over the humeral head posterolateral corner. It is called the heel sac lesion. If a patient is having heel sac lesion and Bengard lesion together, it is surgical. If a patient is having heel sac lesion alone, it is not surgical. If a patient develop a Bengard lesion with a fracture, that is called the bony Bengard, avulsion fracture of the glenoid. So if the patient is having bony Bengard, it is surgical. If a patient is having Bengard lesion and heel sac lesion, it is surgical. Heel sac lesion alone is not surgical. Okay. So for diagnosis of the recurrent instability of the shoulder is the anterior posterior drawer test that shoulder. Okay. In case of recurrent dislocations, for strengthening your shoulder, Shastika Pindaseda, Ashavana, and orthotic shoulder support and exercises. And if you diagnose the patient, this is a normal subacromial space is there, normal glenohumeral, but there will be osteophyte formation. So for diagnosis of the OA shoulder, first one is the osteophyte formation of the humeral head. And in later stage, the ball-like structure will be flattened. So osteophyte along with the flattening of the humeral head is the diagnosis of the OA shoulder. So very, very important, very rare case of OA. Shoulder OA is very rare. And if you get a OA with a, you can see there is osteophyte. Initial stage osteophyte is formed and later the ball-shaped humerus get flattened. So the flattening of the humeral head with osteophyte is the diagnosis of your OA shoulder.